So good morning, I'm Marta Chesi. I'm an associate professor at Mayo Clinic, Arizona, studying multiple myeloma.
And I'm Dr. Leif Bergsagel. I'm a consultant at the Mayo Clinic in Arizona. I'm also a professor of medicine, and I treat patients with multiple myeloma.
And we were here this morning at the IMF meeting in Greece at this session about the cell of origin of multiple myeloma, which was very interesting and very provocative because it's kind of revisit old data and new data about what we think is the cell of origin of myeloma. Is it really what we think is originate from a progression of a post-germinal center B cells that then mature, become a plasma cells onto the bone marrow and form the disease? Or there were evidences that perhaps there are precursor cells that are not actually fully differentiated myeloma cells that can repopulate the myeloma clone after effective therapy. And this, I think, is the clinical context that was discussed, and why this is important is the fact that despite very effective therapy, myeloma almost invariably relapses. And so understanding what are the source of the relapse, I think, is of high clinical importance.
So I had the pleasure to discuss 3 of the abstracts that were presented in this session. The first one was from Dr. Cirincione and Francesco Mauro at the University of Miami. And they looked, using the most advanced genomic techniques, into the initial events that seem to give rise to multiple myeloma. And they've changed our thinking about when it starts. We've always had the idea that the very first genetic lesion occurs in what is called the germinal center during a very critical phase in the life of a B cell. And the data they showed us today is, in fact, that there's maybe a little bit more to it than that there are some additional genetic lesions that we didn't suspect were there, and that may have predisposed these cells to eventually develop into monoclonal gammopathy and multiple myeloma. So that was a pretty exciting first presentation. And then the next 2 presentations really sort of focused on the question you just heard Dr. Chesi talking about, which is what allows the tumor to come back after we've successfully treated it. The idea is that we can get rid of every single trace of a myeloma cell, and the disease can be away for years, but all of a sudden, mysteriously, it can relapse. And the talks talked about the nature of the cells that allow that to happen. The first one was from Dr. Zhao from China, and she had very fascinating data that there are B cells, so the precursors to the myeloma cells, that have got the same genetic abnormality that's a poor prognosis in myeloma, which is the gain of 1q, that causes high level of expression of an oncogene that she characterized there, called FCRL5. And she was able to take that oncogene and put it into B cells and make them turn into myeloma cells, showing that this could really drive the disease, and suggesting that maybe some of the reason these things are high risk is that they allow this reservoir of B cells that maybe escape therapy to eventually come back and relapse and make the disease worse. And then the final talk was, I think, the tour de force was from Roger Tiedemann from the Ontario Cancer Institute. And he had data that he's put together over 10 years. He's followed patients and he's collected samples at different times. And he's been able to track back different cells related to the myeloma cell in the patients and show that these cells have the same genetic abnormalities that are in the myeloma, but they don't look like myeloma. They look like either B cells or just not like myeloma cells. And he had data very clearly that in the patients you could get rid of all the myeloma cells, and when the disease maybe came back 3 years later, it was coming back from these B cells or these non-myeloma cells that were there right at the beginning. So really exciting stuff, don't you think?
Yeah, but I like to add also another level of complexity to this, because the discussion this morning then was about, so is the myeloma originating from a B cell or is all into the plasma cells? But there is also another possibility that is perhaps what I've experienced in mice. I study myeloma in mice, and just because it's much easier to do, get a lot of cells to study, you can follow them more easily. And what I see in mice is this evidence of plasticity in myeloma cells. I have evidence of mice that have clearly a plasma cell tumor. I take out the myeloma cells, I sequence them, so I obtain the genomic footprint of what the tumor is, but then I put them in culture, and somehow these cells evolve and they lose all the marker of a plasma cell, the transcriptional profile typical of plasma cells, and they become not a B cells, but they become a cell that doesn't have any lineage-specific marker. We don't even know how to call them. And I think this is perhaps a way that myeloma evade treatment, is to shut down what makes them. So we have developed over a year a lot of drugs that are very effective at targeting plasma cell-specific biology. We now have immunotherapy that targets surface markers that are typical of plasma cells. Proteasome inhibitor target, the proteasome, the fact that myeloma cells secrete a lot of immunoglobulin, so is constantly under reticulum stress, and IMID target Icaros, that is a transcription factor very important for plasma cell biology. So I'm wondering if a way of surviving this very effective treatment that we have is to actually shut down plasma cell specific transcriptional program and become invisible to the treatment that we currently have that target specifically those factors. So I like to, and in a way it wouldn't be unique to myeloma. We have example in solid tumor of this plasticity. They call it epithelial mesenchymal transition, where epithelial tumors lose some of these their typical marker and turn into more in order to acquire ability to evade and to migrate. So I'm wondering if this plasticity occurs also into myeloma as a response to treatment, mostly.
Yeah. And I think that's the sort of the clinical implication behind this work, is if these are the cells that are contributing to relapse, how can we effectively target them? And studies have been done in the past using antibody to CD20, which is a B cell marker, haven't really been very convincing. More recently, people have tried targeting CD19 and BCMA with CAR T. And it's also clear that that doesn't seem to be curative, at least not in all the patients, because patients have been relapsing from that. And so I think some of the ideas maybe you heard from Marta, if we could control the plasticity of these cells, if we can force them into one state where they might be sensitive, that maybe there's therapeutic implications that we can really target these stem cells and keep the disease from coming back.
Or going back actually to targeting the primary genetic event that drive myeloma, because even in case of transcriptional plasticity, those primary events remain the same. So at least in the cases of translocated myeloma, we assume that if you can target MMSEC, for example, you could keep under control any type of lineage that myeloma can originate.
I'd like to thank you for spending the time to listen to us today. We really enjoyed our time here at the meeting, and hope you're enjoying it as well.
Goodbye.